Delayed recovery from anesthesia. At the end of anesthesia and surgery, the patient should be awake, easily arousable, protecting their airway, maintaining adequate ventilation, and with pain under control. Time to emerge from anesthesia is very variable and depends on many factors related to the patient, type of anesthesia is given, and the length of surgery. Causes of delayed recovery. Residual drug effect. Overdose. Duration and type of anesthesia. Potentiation by other drug, e.g. benzodiazepam on alcohol will potentiate the CNS depressant effects of anesthetics and analgesic drug, which may cause delayed recovery. Prolonged neuromuscular blockage. Drug interactions. Volatile anesthetic agents. Aminoglycosides. Lithium. Diuretics. Calcium channel antagonists. Interactions with depolarizing muscle relaxants, genetic, succinylcholine apnea. Myotonic dystrophy. Acquired acetylcholinesterase deficiency. Pregnancy. Liver disease. Renal failure. Cardiac failure. Thyrotoxicosis. Drugs, ecothiopate, ketamine, oral contraceptive pill, OCP, lidocaine, neostigmine, ester local anesthetics. Respiratory failure. Hypercapnia initially stimulates respiratory center but thereafter depress the respiratory failure, causing hypoventilation and apnea. Hypoxia causes cerebral hypoxia, depressing cerebral function, and finally, cell death. Metabolic derangement. Hypoglycemia. Severe hyperglycemia. Electrolyte imbalance. Hypothermia. Central anticholinergic syndrome. Acidosis. Hypokalemia. Hypermagnesemia. Neurological complication. Cerebral hypoxia. Intracerebral event, hemorrhage, embolism, thrombosis. Hypotension and hypoperfusion of the brain. Investigation. Blood glucose. Blood urea. Serum creatinine. Serum electrolytes. ABG. ECG. Cardiac enzyme. Urinary myoglobin. CVP. CXR. CT scan of brain. Debucane number. CBC. Urinary benzodiazepine. Management. 1. Immediate care. Airway, maintain a clean airway, give O2, reintubate if indicated. Breathing, ensure adequate ventilation, if necessary ventilate the patient effectively via an endotracheal tube, monitor SpO2. Circulation, AS's BP, heart rate, ECG, peripheral perfusion, conscious level, and urine output, resuscitate as indicated. 2. Review the history, investigations, and perioperative management for possible causes of delay in recovery. 3. Intensive monitoring of all hemodynamic parameters, ETCO2, SpO2, CVP, input and output is mandatory. 4. Assess for persisting neuromuscular blockage, using a nerve stimulator if available. Ask the patient to lift their head off the pillows for 5 seconds. If the patient is still paralyzed, they should be sedated or kept anesthetized and ventilated until the block is fully reversed. A further dose of reversal agent, neostigmine 2.5 mg plus glycopyrrolate 0.5 mg on atropine may be tried. In succinylcholine apnea, prolonged ventilation may be required. 5. Look for signs of opioid narcosis, pinpoint pupil and slow respiratory rate. In this situation, a test dose of naloxone be given 4 increment of 100-200 gm. The dose therefore be titrated to effect. 6. Excessive benzodiazepines. Management is supportive with maintenance of airway and ventilation until the drug is metabolized. Flumazenil may be given 4 increment of 0.1 mg to a maximum adult dose of 1 mg 7. Measure the patient's temperature and warm if necessary, warping in blankets and tin foil sheets. Ensuring the room is kept warm and giving warmed fluids will also help. 8. Check blood glucose. Correct with 4-dextrose if it is less than 3 millimoles per liter. 9. Measure and correct plasma electrolytes. Hyponatremia should be corrected slowly. 10. If no other cause can be found for delayed emergence from anesthesia, an intracerebral event may be suspected and full neurological examination should be performed, looking particularly for localizing signs. However, radiological imaging (CT or MRI) is often required to confirm diagnosis. Conclusion. And delayed awaking is common after anesthesia and may have a number of different causes. The primary management is always supportive airway, breathing and circulation, whilst the cause is sought and treated as outlined above. Anesthesia Academy.